To one and all, I am Aishwarya and I am here today to talk about the different diagnostic aids in endodontics. So making the right diagnosis, especially for an endodontic treatment, is of paramount importance because it is very technically demanding of the dentist and requires a high tolerance from the patient. So this can be achieved quite simply by following a set of prompt sequential steps. So diagnosis is an art and science of distinguishing one disease from another. So it can be demonstrated or represented as a flow chart where it is a logical sequence of steps starting from the patient history, which involves the subjective symptoms, and then we go on to the objective clinical tests. And all of this culminates into a definitive pulpal or periapical and periapical diagnosis. So first moving on to the subjective examination. This is the most crucial step. So here we first obtain, after the demographic details, the chief complaint. So the chief complaint has to be recorded in the patient's own words, because that is when we exactly understand what their problem is, what their expectation is of the dentist for the treatment, and also the intensity of whatever it is that they are feeling. And then next we come to the subjective symptoms. So subjective symptoms are reported by the patient themselves. So one of the most common subjective symptoms that they come with is pain. So we have to record the location, onset, nature, duration and character of pain. And then we'll have to look for the aggravating and relieving factors. Like sometimes they tell you that during mastication or talking, during any phonetic action, they have aggravated pain, or that when they consume cold food or some medication, they feel relieved. So we'll have to note this. And then we also have to record the medical and dental history. And then we move on to the objective examination. Here, these are the conditions, these are the symptoms that are elicited or ascertained by the clinician themselves. So we'll have to first do the extraoral examination, which is where we check for any facial asymmetry, lymph node prominence, and intraorally if there is any swelling or sinus tracts and fistula, or if there is any generalized erythema, we check for that. And then during the tooth inspection, we look for the specific caries or fractures or discoloration, or if there are any existing restorations which themselves are a predisposing factor. And then we move on to again palpation. So palpation is done to basically locate and identify the intensity of the pain and to see if there are any swelling, if it is fluctuant enough to perform incision and drainage. And then in percussion, what we do is we tap gently. It can be done from coronally to apically, which is vertical percussion, and can also be done horizontally or laterally. So vertical percussion indicates that the condition has moved to apical periodontitis, and lateral one suggests that there could be trauma from occlusion. And then another test is the mobility depressibility testing. Here the tooth is pushed laterally with two instruments into the socket, and it is also done vertically into the socket. So this is done to determine the periodontal status of the tooth and its prognosis. So treatment should not be carried out in a class 3 mobile tooth unless the pressure on the periodontium is relieved. So it has to be correlated with Miller's classes of mobility. And then we move on to the thermal tests. So here these are done to assess the vitality and health of the dental pulp. These are very important tests. So we do the cold test, heat test and the electrical pulp testing. So in the cold test, we use an ice stick, a CO2 snow dry ice or endo ice spray. So if there is a normal pulp, there is a short, sharp response. And if it is reversible pulpitis, the response is exaggerated, but it is brief. And if it is irreversible pulpitis, there is lingering and intense response. Even after the removal of stimuli, there is pain. And then heat test is done in the case of irreversible pulpitis, because irreversibly inflamed pulp gives results to the heat test. So we use a hot gatapaka or a heated instrument. So this is useful when the chief complaint is the sensitivity to heat. So a healthy pulp will not respond, like I said, and only an irreversibly inflamed pulp will respond with a severe lingering pain. And then electrical pulp testing is done using a tester that is placed on the tooth which is affected. So it can be in the incisal third in the anteriors, and it can be on the middle third of the buccal cusp of the premolars and the mesiobuccal cusp of the molars. So when the circuit is closed, the patient may say that there is a slight tingling or warmth, which will indicate the vitality of the tooth. And then there is the anesthetic test, which is done when the local anesthesia is administered to a single tooth. This is done to localize the source of pain when it is not clear. And then selective biting test is done in case of crown originating fractures, where a biting stick, if for example the tooth sleuth is used and the patient is asked to bite on the stick and there is pain that is noticed while releasing the biting pressure. And then because the type of fracture cannot be identified, like the amount of propagation cannot be identified with the biting test, we go for transillumination. So a light is focused light is shined through the crown of the tooth to detect the cracks or fractures, as light will not pass through the fracture line. Periodontal probing can also be done to identify if it is a endodontic origin or a periodontal origin. And then radiographic tests, they are very important. It is a critical diagnostic aid. So we have a periapical radiograph that will be used to check the single tooth or two teeth along with the periapical region, and a biting radiograph will be taken for proximal caries detection and the marginal integrity or marginal leakage, and also crestal or horizontal bone loss. And then panoramic radiograph can be taken in cases of to identify anatomical landmarks, or when there are multiple pathologies, or when there are large swellings, an OPG will be very helpful. And also this is taken before advanced tests like your CBCT. And then RVG is the most recent one that is taken using that in which a computer is used, so that there is minimal exposure and we don't have to waste time on developing and fixing the solutions. And the last resort test will be a test cavity, where we have to prepare a cavity without using anesthesia. A positive response will indicate a vital pulp. So all these data that we get, we have to not only rely on one test, because multiple problems can give positives to one test. So we'll have to take multiple tests and synthesize objective results and then give the diagnosis. So we also have advanced diagnostic aids like the CBCT, ultrasound and pulse oximetry and laser Doppler flowmetry. And pulpal diagnosis can be reversible, irreversible pulpal necrosis, or it can be a previously treated tooth. And periapical diagnosis can be symptomatic apical periodontitis, asymptomatic apical periodontitis, acute chronic apical abscess, and can also lead to, in the end, condensing osteitis. So the conclusion is that an accurate diagnosis is the foundation of successful endodontic therapy. Systematic evidence-based approach is key, and we'll have to utilize a combination of subjective and objective tests. Thank you.